Welcome to this next section of the AHIP conference. My name is Dr. Scott Shreve, and I will be conducting this session. This is the Connected Primary Health Model, Improving Care Delivery and Health Outcomes. I am the CEO and founder of Crossover Health, and joining me today on this panel is Caitlin Johnson, who is the Senior Manager of Life Connection Centers at Cisco Systems, as well as Sam Glick, the Global Healthcare Practice Leader for Oliver Wyman. All right, well, to kick this session off, I wanted to introduce the concept of commercial advantage, which we think is a pretty novel, unique way to improve both care delivery and the health outcomes by involving benefit design and the payment model together. So let me introduce the topic by talking about the quadruple aim. We often hear about the triple aim of cost, quality, and experience, but as a healthcare provider, we also care a lot about how our care teams are doing. And so we believe balancing all four of these objectives simultaneously is the trick that we hope to be able to perform. And over the years, people have looked back at how can healthcare be better? How can we get better costs? How can we get better quality? And how can we have a great experience for both the member and the provider? And really, people thought this might be impossible. You can't do all four things at once. Well, we disagree with that. We actually think they can be done. And particularly when you can have alignment between the employer, the care delivery arm, and the payer as well. So with that, the quadruple aim, again, to spell that out, if you can put all of these things together and bring them together and align them, then you can achieve the outcomes. And really, that is the intent of commercial advantage. Now, where does this term come from? What are we talking about when we say commercial advantage? Well, many people are more familiar with the idea of Medicare Advantage. This is a program that has been in effect since around 2000, and it's seen an incredible increase in the number of people enrolled in this plan. These are all Medicare beneficiaries, and it's a combination of Part A, Part B, and Part D, and all those services together are paid for in a unique and novel way. New and innovative primary care delivery organizations have sprung up over this, that they have begun to enroll patients. They develop new capabilities, new services, new offerings that compete in all these different markets and deliver an exceptional result. What's interesting about Medicare Advantage is it's a very advanced form of primary care. It has moved past fee-for-service, it's beyond incentives, and it actually starts to become a completely aligned health plan based on full capitation. And so when you align care model with payment, with benefit design, you can actually achieve some great results. And so the most innovative healthcare delivery organizations are at this most sophisticated end of the spectrum. But for employers, they're actually not there yet. They're much further back, about 4 to 5, maybe 6, 7 years behind where the most advanced Medicare Advantage players are. So what this creates is an opportunity for the commercial sector to learn from Medicare Advantage. And can we create a commercial advantage equivalent? And so with that idea in mind, that's what we're introducing today. What's interesting is some of the most innovative thought leaders in the space have thought a lot about this and suggest that we do this, but they've identified a conundrum that has historically existed. And this is Atul Gawande commenting on this issue. You know, over the last 20 years, there's been a variety of different settings in which cost control and cost containment and care delivery have been tried. And the challenge has been you either have access to the patients, but you don't control or can't change what the providers are doing, or the other way around, you control the providers, but you don't really have access to the population. You can't align the incentives properly. And what we're talking about today is an alternative to do that with commercial advantage. The concept is it's similarly structured to what Medicare Advantage is. It's a plan design, it's a payment model. Members elect into the plan, and as part of that plan, they get full comprehensive primary care. They get steered, guided, and navigated to a high-performing network, and the payment is administered by an ASO or TPA. And so when you combine these things, you can then begin to really drive towards the quadruple aim. So in this setting, Crossover has been introducing this plan to our employer partners and our payer partners over the last 6 months. And working closely with the benefit consultants, ASOs, TPAs, and others, we've been able to bring our comprehensive care model, tie it to a benefit design, and then ensure that a payment model lines up with it as well. So what you can see is that if I start to look at these constituent parts, you can see how all the elements and the different stakeholders that are involved in bringing these types of programs together. So typically you'll have an advisory firm, a consultant that's helping an employer think through this. They'll involve actuaries. They'll look at the benefit design elements and they'll work together to bring those to the right balance. You'll also bring in a care delivery partner. In this case, Crossover Health. We bring a wide range of services. We're national in scope. We're proactive in our approach. And that is really critical to help serve the needs of these employers who are all over the country. You also have to bring the network to bear. As everyone knows, 85% or more of the spending actually happens in the network, not in primary care. So you need partners who line up with this philosophy and are willing to organize around that type of care model. And finally, you need to have administrative partners and payers that can literally make the payments go in this more capitated form of care. And so TPA and ASO partners are absolutely required to be able to deliver on these types of programs. So let's break it down even a little bit further. So again, on the right, as you look at Medicare Advantage, it's Part A, B, and D all combined together. And then of course, they add additional services, dental, fitness, hearing, vision, all together, care, plan, and payment together. So let's look at those. So when commercial sector starts to look at this, well, what does that mean for the plan design? How would the plan design change to actually create a commercial advantage plan? Well, typically what you're going to find is you're going to have lower copays, lower premiums, but higher accountability to deliver on the outcomes necessary to make these plans work. You'll also find that care management and care navigation are embedded in the design so that you start with those navigators. They're the ones that are steering and guiding you into the network. When you have medical conditions that need to be managed, you're engaging with a care manager as well. And that's critically important to controlling the cost. In addition, as part of the plan selection, you elect into joining one of these care delivery innovators like Crossover Health. So it's a voluntary election of defined members into designated care teams. Those designated care teams then are accountable for the outcomes that are achieved. This is why they are focused on being proactive and preventive and monitoring the health of the population so that they can stay on top of cost, quality, and the experience. The other thing you'll notice about these innovative medical groups like Crossover is we bring quite a bit of other types of programming. We're not just waiting until you're sick to come in and see us. We're trying to actively engage you in your health. We offer webinars, seminars, affinity groups, fitness, health coaching, and other types of programming that allows people to really engage on their health, to have an annual health strategy, and to be working towards accomplishing their objectives. And finally, these plan designs have to have a lot of accountability built in, and that accountability should line up with the goals of the quadruple aim. It'll be around cost management, care quality, member experience, and provider satisfaction. And when you bring all those things together, you can see how these actually look. So if you look at the structure and the concept of this, you can see that the plan design fits like a glove with the care delivery model, which ties intimately in with the payment. And when you line those three things up, magic can actually happen. So let's look at this a little bit. Of interest, Crossover Health itself as a company is a self-insured entity. And we are actually sipping our own champagne on this one because we designed a commercial advantage plan that was offered in the 2021 plan year. People had the choice to elect into Crossover, and if they followed and worked with our care navigators, their referrals into the network were going to be zero cost. So anything that was navigated, whether it was primary care specialist or any other service, it was at zero cost. We also lowered the premium, and we created different incentives for the members who joined this plan. Of interest, 70% of the eligible employees joined this plan, and we had great uptake, which was fantastic. And so we think, as you compare these plans against traditional, we think that the consumers will love it, but it also is driving the behaviors, creating the incentives and the alignment necessary to achieve those quadruple aim outcomes. Now, like with everything, there are challenges with commercial advantage as well. And a couple of those challenges we highlight here. You typically, in the commercial space, people are well enough to work. And so typically they're healthy, a certain level of health. And so the PEPMs or the monthly premiums are much lower. And so can you create these models and can they be profitable with a much lower premium base? And can you reliably get the leverage you need to be more efficient? And this is why these services and these providers are so technology capable. They're using data in smart ways because they have to be efficient to operate underneath the budgets that are created. The other thing with plan design is, will employees understand the value of and elect into commercial advantage? And in our case at Crossover, we saw that 70% of our employees joined the plan, which is phenomenal. And also, can benefit designs be effectively and efficiently administered by the ASO and TPA? These capitated arrangements, value-based payments, and other things are much different than fee-for-service, which most of the systems were built for. And so can these new models be cleanly and effectively administered? Finally, as you look at the incentives for both the members, the providers, and the payers, can we create a concierge default experience versus this direct compulsion of traditional narrow networks? What I mean by that is, can we make the experience so exceptional that we are naturally guiding you to the two best providers without making you feel like you're compelled to only see the two providers in the network? That's part of the magic of these high-touch, high-tech models. And finally, is there enough volume to offset the lower payments potentially to the providers in the network? And is there enough premiums to make this work for the payer and the providers? So these concepts, these innovations are not without their challenges, but we think they're all overcomable. So with that, let's turn the time over to Caitlin Johnson, who's going to share her experience with the benefit design innovation at Cisco. Caitlin?
Thank you, Scott. It's an honor to be here and with you on your panel. Yes, I would be happy to share Life Connections and the story around Life Connections. So it was actually over 10 years ago that Cisco saw the need for access to excellent primary care services. So we launched the first medical home model way back in 2008. And that model was designed to be an integrated whole person care with primary care at the hub, at the center, but also ancillary services. So basically you could get your core preventative care, but also urgent care under one roof. So as you can see here, we started out with primary care, but what did we also do? We said, you know what? Cisco is a family unit. We have employees with families. Let's take care of everybody within the family, because that's where healthcare starts as well. So we have pediatric care. We do service infants. So we take care of the newborns all the way to when people retire. We also brought on counselors. So we had EAP counselors in the house working side by side with our primary care physicians. And then we did bring in some specialty care, such as dermatology. And then for convenience, we have on-site lab, X-ray, obviously we do travel medicine. And then we also built out, because eye health is extremely important, a vision center. And of course, to complement the whole person health, we also have a dental center. But then with that, one of our top cost drivers is musculoskeletal, right? That back pain, neck pain, shoulder pain, sports injuries. So that's where we have chiropractic and physical therapy, along with some Eastern philosophies, and that's Chinese medicine and acupuncture. And with that, a whole service pharmacy and convenience. We're open till 7 p.m., also open on weekends, particularly Saturdays. So the model is not just about access, it's about access to quality integrated care to service the whole person. We started this in 2008, and we continue to grow our program across the globe at our major campus sites. We don't mandate our Cisco employees and their families to use Life Connections. So we have to compete with a basically top market in the Bay Area and North Carolina. So why would an employee want to come use our Life Connections centers? One, extremely cost efficient. You will pay less coming to our center versus a community doctor down the street. Super convenient. We demand same day access, right? You don't have to wait for appointments. And as I mentioned earlier, super good hours. Quality services is also top priority for us. So we both use Stanford Healthcare and Crossover. We added you to our portfolio just last year. So we now have access to wonderful Crossover in San Francisco. And of course, as I mentioned earlier, it's all about convenience, but integration and whole person health, which you most likely cannot get in a typical doctor's office. Next slide. So here's the big story. Okay, we provide concierge care. We provide access to that concierge care, more time with the physician. But what does this translate for Cisco? How does this translate financially for the patient, but also for our bottom line? Here's a 10-year snapshot, right? 10 years of data, year over year, risk adjusted. I am comparing here. The blue line is Life Connections Health Center. The green line, everybody who doesn't use Life Connections Health Center, but uses the community. You can see year over year for 10-year period, we've had a lower per member per cost. This is significant as the community keeps driving. Now in the Bay Area, we still have some trend going up. We had some catastrophic claims, but you can see the gap significant. And look at North Carolina, our RTP campus. What's happening there? Our costs are actually declining, where, well, inflation is going up, right? Costs are exploding in the community. We are super impressed with these results. So what did we do? In 2017, particularly in the Bay Area, we said, we could do more. We need to actually create a medical plan where Life Connections Health Center, this medical home hub, is the base. It's the core of an ecosystem. It's the core of an ecosystem that's actually a custom closed network plan where the primary care providers labeled the personal physician or the health coach. And that's exactly what we did. So let's shift to the next slide and talk about how we created the Life Connections medical plans. We had a vision, a strategy, and then we executed on that strategy. And we started this work in 2015, okay? Our goal, our vision was to transform healthcare and the entire delivery model to maximize value, right? And health outcomes using Life Connections as that medical hub. And I'm also putting crossover because they're now part of the plan. That said, what was our strategy? We want to launch a value-based, high-performing, accountable care closed network health plan. So what did we do? We direct contracted with a prestigious healthcare system. That was Stanford Healthcare. We're using Life Connections as that medical care hub, but you don't have to use Life Connections when you roll in the plan. So that's critical as well. You can use other primary care doctors, but of course you'll get the best advantage using your own Life Connection center. We do require the primary care doctor to be the physician coach, to be the health coach. So every member who enrolls in the plan has a primary care. Now, this primary care doctor is not a gateway to specialty care. You could still refer and go to specialty care on your own, pending the type of specialist, of course. But we really wanted that primary care doctor to make sure they know exactly what their patient is doing, their family members, what have you. So the patient isn't navigating the healthcare system on their own. And as Scott said earlier, plan design is really critical. So we created a very attractive plan design for the patient, for the member, so that they pay less being in this plan, because what is it? It's a closed network. We don't have an out of tier. There is no out of tier. It's one tier, and that's the closed network with Stanford Healthcare. We also use a wrap provider with our TPA, but we hand selected the specialists that are going to be in this plan. So how do we drive execution? Well, it's critical that we focus on utilization and how members utilize the plan with excellent, what I'm going to call clinical care management and case management, not with the health plan though, but with the provider. So the provider is completely responsible for the outcomes of that care, but also for the financials. This plan has both upside and downside risk with target budgets, okay? So that's critical because the healthcare system delivering the care needs to be accountable to that care, both financially, but also, of course, clinically. So our metrics, this is what I look at day over day, if you will, in our new Life Connections medical plans. It's our enrollment. We have to have a robust plan to compete with our other plans at Cisco, which, by the way, we offer choice. We did not rip out any other plan. We just added plans. So we have to compete with our other plans that employees can choose from during open enrollment. Utilization, and that's not just how are you using physicians and unit costs per se. It's how well are the primary care physicians performing in the plan? How well are people using their primary care doctors? What are the referral patterns like? Also specialty drugs, making sure it's the right drug, right time. And then, of course, a critical metric is what we call the budget target. So Stanford Healthcare, for instance, is required to hit a very, very aggressive budget. And it's not if I say slow the trend, they have to decrease costs year over year from the previous year, which is not easy to do. And I have to say, of the 5 years the plan has now been performing, we've exceeded, if you will, our target budget 4 out of the 5 years. So we're very impressed with how this plan is to date performing. So with that, I think, Scott, that's my last slide. This just gives an overview of how we built the closed custom network. And I do want to say it's regional. This is based in the Bay Area.
Thank you, Caitlin. Appreciate that background. We have time for about 2 questions for you at this point. So one of the things I wanted to hear from you was your experience in designing the healthcare benefits that mapped to the Life Connections program. How did you create that alignment between the benefit design and the care model itself? What were the things you learned there?
Yeah, that good question. So benefit design is critical. So what did we do? We carefully analyzed all of our plans at the table, and we looked at, okay, how are we going to make this plan attractive, but we're not going to give it away. We wanted to make sure there was some skin in the game for the employee enrolling in the plan, but our actuarial values are around 0.9 or 90%. So there's still some cost share with the patient. But Cisco, as I mentioned earlier, we provide choice. So this plan is standing up against Kaiser Permanente, a HMO with very low copays, but then I also have a national HSA and a PPO plan right next to it. So we had to make our plan design extremely competitive, but not free, okay? And we also had to make sure it's still aligned with the national plans. So people could say, yeah, I will enroll in this custom narrow network plan. I won't have the same freedoms of going to any doctor, but I'm going to pay less and get better access to care. So those all have to fit together to make this plan work.
Yeah, that makes a lot of sense. And then as a final question, you guys were very early to include and incorporate mental health into this. 10 years ago, you had that. What did you see a decade ago that allowed you to understand how important that service line would be? And how do you view mental health as part of this management program that you guys have?
Yeah, as I mentioned, you know, we added counselors to the provider panel very early on in 2008, because we saw that this is about whole person health. This is about taking care of the person before they get to a catastrophic case, right? And that's physical, mental, and even spiritual, if you will. Today, it's now even more advanced. So we've created an integrated primary care health model where we've brought on a psychiatrist who will manage a registry of patients, training the primary care physicians or teaching the primary care physicians how to manage depression, anxiety, and other mental health conditions along the spectrum. So we don't have to refer everybody out to a psychiatrist, for instance, for the more advanced cases. We also still think, though, access to mental health care and the right mental health care is a critical need. So what we're seeing today is a lot of companies using technology. So there's an explosion of new companies using technology to help patients along care continuum get the right type of mental health support. So we're still working on that as well at Cisco, and it's a big need, particularly through this
Right.
pandemic, as we all know.
Yep. Okay. Thank you, Caitlin. Appreciate that. Let's go ahead and switch gears here. Let's bring Sam on the virtual stage here now. Sam, you obviously have an incredible background in this, working with employers, health plans for decades. Do you mind sharing your experience and your background in watching these care delivery models and payment models kind of evolve over the last decade or so?
Yeah, happy to, and it's good to be here with both of you. As you mentioned, I have the privilege. I spend most of my time with large health plans and providers across the country, helping them think about how they really differentiate in the marketplace, how they think about controlling costs, how they think about serving employers like Caitlin, and making sure they're providing the best possible products. And as part of that, particularly in recent years, health plans will often come to the question, well, should I own care delivery? Should I, vertically integrate, as they say? And my first question back to them is, why? And I don't mean that in a kind of rhetorical way. I think it's actually really important for a health plan to reflect on, what am I trying to achieve in bringing care delivery to be connected with the products that I offer? In some cases, it's simple revenue diversification. I'm in a big regulated business, and care delivery is a different kind of business, and that's what I want to do. And famously, more than a dozen years ago, United Healthcare created Optum, right? That was a diversification kind of play, and now care delivery is a big piece of that. But that's a very different kind of play than perhaps I feel like the provider network that's dominant in my service area isn't providing the kind of customer experience, consumer experience that I want my members to have. That's very different than I have an employer who's demanding that I control costs differently, and I don't feel like I can do that with the network relationships that I have. And that's different than, maybe I actually want to perform in something like Medicare Advantage. And so the first question is, well, why am I doing this? And we often see kind of 8 common reasons. Is it an access issue? This was actually sort of the primary case for a lot of the initial vertical integration things. I've got pockets of my network where people can't get an appointment the way they need, or I don't have specialists, so I got to buy it, right? I've got to create incentives for people to do that. Am I looking for growth? Maybe I'm not the largest health plan in my service area, and what I want is an opportunity for people to experience my brand, and then maybe sign up for my plan afterwards. And we've seen this particularly in states that have 2 Blues plans, for example, figure out what it's like to be with us. Maybe I need some negotiating leverage with the other providers in town. If there's only 1 or 2, they tend to set the terms of the contract. And if I've got another option, that becomes a more balanced negotiation. Maybe it's utilization. As Caitlin alluded to, primary care is 6 to 8% of the total cost, but it controls nearly all of the total costs. And so there's a big leverage point in that, as we think about being able to manage referrals for a commercial population, or being able to do effective care management for a Medicare kind of population. And that's a big piece. Maybe I'm in a place where I don't have the kind of quality that I want, not Caitlin's issue in the Bay Area, but there are parts of this country where we really need to raise the bar, and you want to do that. Maybe I just want a different customer experience. Maybe it's the providers in town, or the kind of usual dismal waiting room, and not digitally enabled, not trying to make it seamless, spend 3 hours getting in and doing the paperwork. And I want people to I really want to own that consumer relationship. Maybe it's risk coding efficiency, really matters in Medicare Advantage. Or maybe, as I said, it's diversification. But as you start to dig into this as a health plan, you'll go very different directions. And I think that's actually the power of this, which is you say, well, if it's diversification, that's probably an acquisition strategy. That's probably go buy some providers in town and run them in a separate business unit. If it's something like risk coding efficiency, customer experience, clinical model quality and safety, then I really need to be in the business, like Caitlin described, of what's the clinical workflow? What's the customer workflow? How am I designing those sort of best in class? And I need either a really good partner like Crossover, or I need to hire executives who really know how to be in care delivery, which is a lot of health plans don't necessarily do. And then if it's the stuff at the top, I really got to focus on the product I'm putting around it. How do I do the right plan designs? You know, Caitlin talked about how at Cisco, she's competing with 3 health plans with a plan design. This wasn't just stand up an employee clinic and walk away. It's not a kind of field of dreams strategy. You have to be comprehensive. And so, you know, I think what's exciting is vertical integration done right can actually start to transform the business the health plan sees themselves in. But it can't just be about the care delivery. It can't just be, well, I'm going to get some clinics, I'm going to get some doctors. You got to be designing the right customer experience. You got to be putting a product around it. You've actually probably got to have the data and the infrastructure to manage referrals. You got to be a great place to work. It's not like it's easy to hire physicians everywhere in the country and the clinicians they work with. And you've got to take a kind of holistic view. And, you know, different places will take different strategies, but that's a lot of work. That's a lot of work. And some of that is scale work. And so having a partner who can tailor locally, but have a national platform for care can leverage a lot of that scale, can bring some of that scale, and just bring a lot of expertise, because it's a different business than running a health plan.
Yeah, absolutely. You know, you have such a unique role because you get to see so much of what the market is doing and so forth. And I'd be curious to see how you're seeing, how are health plans thinking about primary care specifically, and some of the things that Caitlin is doing around this comprehensive, integrated, coordinated care models. Where are the health plans in evaluating that and participating that and driving that?
Yeah, I would say this is probably one of the hottest topics I've talked about with my clients in the past few years, each for different reasons, you know, the ones listed on this page. But it's really important. And they're each taking different strategies. You know, the ones who are focused on Medicare Advantage are thinking more, or even managed Medicaid, are much more about care management and complex care models, and actually extending even beyond the kinds of things that Caitlin's doing into new kinds of home care models, for example. Others are saying, now this is actually how, when we go out and do the employer RFP, we break out of the, you know, sort of undifferentiated sea of sameness among health plans, right? To say we can actually bring you a different kind of solution. But I would say everybody's talking about it, and a lot of plans are either investing in it or considering doing it very soon.
Yeah. And again, we've seen a lot of that innovation in the Medicare Advantage space, as we talked about earlier. What do you see the role of commercial Advantage equivalent? Is there a role, and how should that be implemented by both employers or as by payers? Like, how do you have them approach this challenge?
Yeah, it's a great question. You know, there's a lot of reasons, and I loved your chart about sort of how Medicare Advantage brings together all the different aspects of care. But the other two things I think that have been really powerful and driven this huge growth in Medicare Advantage. I mean, Medicare Advantage penetration has gone up dramatically. One is that it forces health plans to compete on more than just premium or more than just the breadth of network. That Medicare Advantage, if the quality is high and you get 5 stars, you get to market more and you get to market better. You can offer ancillary benefits that bring people in. And sure, there's some premium and cost share, but that range is not as big as in the commercial market. And you're really having to compete on experience and features. The other thing is it aligned the incentives and behaviors of the plans and providers. So when we look at those Medicare Advantage stars ratings, we do an analysis on a weighted basis. The points you get for a stars rating, 75+% of those are controlled by the provider, not by the plan, even though the plan gets rated on that. And I think there's a lot of potential to bring that into the commercial space. If you think about what employers want, you know, they're not buying insurance, right? They want to buy a care experience for their employees that is high quality and low cost and delights them and plays a meaningful role in keeping them healthy. And that kind of integration that Medicare Advantage has, I think, applies in commercial as well. And then frankly, these kinds of integrated solutions, I think, help to plug the gap for a lot of commercially insured people who are mostly well. You know, we talk a lot about people who have chronic conditions and other health challenges, but you know, nearly 80% of people are going to get 2 or 3 primary care visits a year, a prescription a month, and go about their lives until something bad happens, or until they have a scare, and that happens every so often. But the challenge for them is some of the sort of pure telehealth solutions don't have that last mile, and you do need to lay hands every so often. You need to connect with people. Urgent care overtreats, and if they go to the traditional system, they never get let go, right? Once they're in it, it's the Hotel California a little bit there. And so this idea of you can build a solution that's an integrated care solution that meets all of those needs, I think is really attractive to a lot of people who aren't necessarily regular health system users.
Yep. That's interesting. Well, let's do this. Thank you, Sam, for those comments. Caitlin, let's have you kind of rejoin us, if you will. One of the things I thought would be interesting for the audience is, Caitlin, you had this success as an employer. We're using the employer as the framework to kind of say, hey, here's what innovative employers are doing. But let's just say, Caitlin, you had a brand new job at company XYZ. There was a whiteboard in front of you, and you and Sam is your advisor, and you guys are going to partner to create a plan. Where do you guys start? How do you go about this? There's no constraints, no limitations. Where would you go? What would you guys come up with? And I'd love to see the banter as you guys kind of start designing and thinking through what you're trying to accomplish there. Let's start with you, Caitlin, and then have Sam jump in.
I love this question. And I want to play off what Sam just said. How do we tailor a plan for all the members, the low utilizers and the super high utilizers? I just looked at data yesterday where it's still 5% of our members are driving 61% of the total cost, right? So first, it's like, okay, how do we build a plan for this 5 to 10, 15% that are high risk, right? How do we really address that? Because I don't know if we've done a good job in that, right? So it's really focusing on an experience and a safety mechanism to provide the best care for these folks. But then I'm shifting to another cost driver, and that is RX specialty spend. How do we design a plan to figure out how to reduce specialty RX? Because that's what's making our costs go through the roof, regardless of your utilization, right? And then the third element that I'd really like to whiteboard is how do companies like Cisco control the contracting and fee schedules? So right now, although we love my plan, I still don't control the rates. Our TPA does. So how do we do a better job being engaged in the contracts when it comes to paying the physicians so that we can pay our primary care doctors more for the work they're doing and figure out how to reward the right type of care and reward the physicians that are really driving the right type of utilization. So that's where I'd like to start. That's where I'd start. Sam.
I love it, Caitlin. I would double down on the pharmacy point. We did an analysis of commercial claims across the country, and we all know the population pyramid you just described for overall costs. For pharmacy costs, 1% of commercial members are 35% of the nation's pharmacy costs for that population, and you only need 10% to get 85%. So the pharmacy population pyramid is like the Space Needle. It's just way up there, and we do not have the same muscles around how you manage those costs, around the kind of care models that can reduce utilization and direct people in the right places that we do for diabetes or COPD or other things that can lead to hospitalization. So I think that's a big whiteboard piece. The one I might add to you that's really interesting is, a lot of times when we talk about affordability, we're really talking about system affordability, employer affordability. But consumer affordability drives a lot of behavior too. And where consumers are spending their out-of-pocket is in very different places. By the time they land in the hospital, which is driving the biggest portion of employer costs, they've actually met their deductible, many times met their out-of-pocket maximum. So they're spending more than 3/4 of their money on drugs and professional services when we look at the data. And they get hit. High deductible health plans mean if your family gets the flu in January, February, you may spend $2,000 by the time everybody goes through the system. And that's a lot. And so I think you'd also start from a white sheet of paper and say, what do we do to actually align those cost incentives in the right way? Is it thinking about co-pays, not co-insurance and deductibles? Is it thinking about monthly deductibles, not annual ones? Is it thinking about ways that you actually make it so that people engage with their health the way you want? Because I think that's that's a really important piece of making sure people get the care they need from primary care before they have a much bigger cost.
That's brilliant. I have to say, Scott, I would love to look at a model like that, because these high deductible plans, we're really not controlling the cost. The costs are still escalating, and in some sense, we just pass the cost to the member. So that's a great call out, Sam.
And what are the roles of the incentives that the plan design can kind of generate? Like, where are the biggest lever points on the design itself that you're finding, or how would you guys whiteboard that out?
Yeah, I mean, if you think about the plan design, and this is I think one of the kind of great myths of plan design. Plan designs are primarily effective at cost shifting. They don't actually control utilization as much as we think. And if you talk to any actuary at a health plan, they'll tell you that that's not primarily about controlling utilization once you get past a certain level. It's just a matter of controlling costs by having somebody else pay it. The other thing we see is that there's dramatic difference in how consumers respond to plan design. People want predictability. It's actually one of the top consumer needs that we see. It's one of the things that scares them away from the health system. We did some focus groups where we asked people all their sort of consumer hassles with healthcare. And one guy said to me, I wish my doctor's office was like the pharmacy. And I said, what do you mean? And he said, I go to the pharmacy, they tell me how much it's going to be. Maybe it's really expensive, but I know that if I leave with the drug, I could afford it because they're not going to send me a bill later.
Yeah.
Which I thought was a really interesting point, right? He pulls out his credit card, he bought his drug, he was done. And that's how consumers know how to engage. And so, I think big levers and things like, seriously, copays, not co-insurance and deductibles, right? So that they're predictable. Thinking about how you pay at point of care. I think having an integrated kind of system like Caitlin was talking about, you'll know what somebody's going to cost. You can collect it. You could keep a card on file, right? That's the kind of consumer experience people want. It's the predictability that matters a lot.
Yeah, I think that's great. I know we're coming up on time here, so I'd like to, Caitlin, would you mind just kind of summarizing the thoughts that you'd like to leave with the audience and kind of summary here? And then Sam, I'll ask you to do the same. Caitlin?
Yeah, thank you, Scott. So it's all about access to excellent care, but it's the right care. And looking at your care models matters. It's taking the best of the best and creating a solution to transform it and not go with the status quo. And I love what Sam just said. Plan designs are all about utilization and cost shifting. That's not where we want to take healthcare. We do want it to be an easy consumer model that's not difficult to digest. And I think what we've done is made it really hard to digest. Benefit lingo, very complicated plan designs to understand. And then, of course, a system that's hard for commercial companies to manage. So I would tackle the problems one by one and do the best you can to make that quadruple aim work for your system.
Love it. Thank you. And Sam, how would you wrap up and summarize for our audience?
I think Caitlin put it well. Don't let the perfect be the enemy of the good. So often working with health plans, they want to get the whole grand design perfect, and it'll take them 5 years to build anything. And what about if this provider in town reacts? And what about these members who might feel excluded? And what about the blue card issues? And what about this? And what about that? Just do something. Just start. Build something that's okay V1 in the first year. And if people like it, you'll have permission to do it the second year, and you'll have permission to do it in the third year. This is building a product. This is building a product from scratch, and you gotta just move.
Yeah, I love it. It's that bias for action that we like to talk about, right? So,
Yep.
All right. So let me leave the audience with 3 things we hope you walk away with. Number 1, advanced primary health with integrated care teams and a set of services that is meeting the needs is critical to value-based, results-driven health and well-being. We wanted to highlight today that behavioral health is a critical component of whole health, and it should be offered at parity within this primary health service. We also believe that the benefit design, as we just heard, is really important to default with the right steerage, the right incentives, the right alignment, the right payment, to achieve the right outcomes, as Caitlin mentioned. So I want to thank both Caitlin and Sam for joining me today to introduce Commercial Advantage as an alternative opportunity for health plans and employers to look at. And thank you guys for attending and being a part of this.